Good morning, everyone. Thanks for showing up a little bit early. I'm Rob. I'm going to talk about differentiated thyroid cancer. And, oh God, Carl's going to talk about cancer. For what it's worth, I feel kind of the same way about thyroid cancer when we're making these slides. There's a lot of, as we're about to go into, thyroid cancer is somewhat unique in that while there's an abundance of data, almost none of it are randomized. And there's a lot of changing in how we manage these patients based on mostly how the wind's blowing and the strength of opinions, both of your surgeons and your medical endocrinologists. And that leads to a lot of crying and vomiting at the same time. So let's go into that. What we're going to hit on today, a little bit of biology and incidence trends. There's a lot of trivia in this part that is important for testing purposes, which has little to any actionable clinical management change. The other one's board answers for workup and treatment. There's going to be kind of the guidelines and like this is what we say we do. But what we're really going to talk about is the reasons underpinning those, which are very few. And we're going to talk about some of the gray areas and maybe where if you want to stake your claim as an academician, can really contribute to the future care of our patients. And then some controversies, because these always show up in every cancer talk, but particularly in thyroid cancer, there's a lot of fighting that goes on about how we actually manage these patients. If you're going to learn nothing else, take home points, okay? First, differentiated thyroid cancer, and we're going to specifically know what that means, has excellent long-term outcomes. Everybody remembers one patient that did really badly, but 99% of these patients have survival that is measured in the decades. This is a data-free zone. There's only about I'm only over one randomized trial for you today. In general, we, surgeons, medical endocrinologists, overtreat patients with thyroid cancer. Treatment variations require knowledge of your institution-specific data. This is important when you're going out into the world. If you're going to be doing thyroids, you need to know how good your ultrasonographers and CT techs are, because a lot of how we diagnose thyroid cancer is based on ultrasound, and a lot of how we follow thyroid cancer patients is based on ultrasound. You ought to know how good your pathologists and your cytopathologists are, because they're the ones who are telling us whether or not the patient has cancer in the first place. And they kickstart the treatment process for all these patients, and you can overtreat very quickly based on a misread. And then your own surgery outcomes. So we're going to talk a lot about risks and benefits. You hear about all this all the time on your rotation, but is what we're going to do to the patient worth it? When in doubt, total thyroidectomy is a safe answer for our chiefs out there. When in doubt, total, okay? Nice, moving on. Biology and incidence. So we're going to talk about differentiated thyroid cancer. And by that, differentiated thyroid cancers take up iodine. That's all that means. So differentiated tumors still kind of act like their parent organ. So a well-differentiated gastric cancer still kind of looks like gastric cancer, like the stomach mucosa under the microscope. Same thing with thyroid. Differentiated thyroid cancer behaves like thyroid tissue, not as well. It doesn't work as efficiently as thyroid tissue in how it does it, but because it's like it takes up iodine, and we exploit that in how we treat these patients. Within the differentiated thyroid cancers, there's a bunch of like subtypes. Oh, I should have brought my pointer, but by and large, like the vast majority of these are papillary thyroid cancers. And then when you see the right side of the screen, that's blowing up the papillary thyroid cancers. Within that, about a quarter of those patients don't even have cancer. That's that encapsulated tumor. We call it NIFT-P now. It used to be called an encapsulated follicular variant. Either one of them are benign. So within the majority of our thyroid cancers, about a quarter of those are already benign. So, all right. And then 33%, a third of those patients have microcancer. That's defined as a cancer that is smaller than 1 centimeter. And those behave in such a good fashion that we're not even operating on those all the time anymore. And then the classical variants. And then up at the top of the screen on panel B, you're seeing the ones that we think about that are a little bit more concerning, like the tall cells. You'll hear hobnail. Those are kind of, they're kind of synonyms, but they're just depicting something that looks ugly under the microscope. And we think they may behave a little bit worse than the classic type papillaries over the long term. Oh, basic science. All right, so this is how we think it happens. So you're taking a standard follicular cell. Something happens, MAP kinase pathway gets activated, typically through a BRAF mutation, and then, or a RET fusion. And those tend to differentiate more towards the papillary kind of cancers. In contrast, the PI3K, ATK pathway can get activated because of a mutation that we don't understand. And that's more associated with RAS mutations that can get you more down towards a follicular thyroid cancer. None of these are like gospel, but just in general, the BRAF mutations are more associated with papillary cancer and the RAS mutations with other kinds of cancers. Both of these on the bottom, the TERT promoter, you may see this coming up in testing and in real life. TERT promoters does something with telomerase, which acts on the end of chromatin and does weird stuff. But anyway, TERT mutations can kind of predispose to both of these things happening. So people with TERT mutations now we think are genetically predisposed to getting thyroid cancer, as well as other cancers too, like melanoma. So more on that to follow for your basic science types. This is what it looks like under the microscope. Papillae, yeah, especially on the right side of the papilla, you can see it's this fibrovascular core. It's got little fronds poking out. That's what a papillary tumor looks like. And then you can see on the right side, follicles with cancer cells. Follicles are the red circle. The circle's filled with red with kind of ugly looking cells surrounding it. That's just abnormal follicles. This is why they call it differentiated. It's still trying to act like a thyroid, but it doesn't look quite right. They talk about some of these pathognomonic findings. One of these big vacuous nuclei, they call it Orphan Annie. None of us are old enough to have actually read Orphan Annie comics, but apparently she was a kind of a psychotic looking cartoon with either no eyes or like, I guess in a more deranged photo on the right. And that's kind of more like what we would think about with papillary thyroid cancer, but that's where they get it from. It's this cartoon from the way before all of our time. Other things you will hear, buzzwords, both on tests and with your pathologists, is you'll hear nuclear overlapping. That's in the top left. That's where it just looks like the nuclei are all clumped together. Nuclear grooves, that's part of that psychotic looking Orphan Annie nuclei looking thing. And then on the bottom is a Samoma body, which is this kind of concentric calcified thing. It's really helpful. If you hear Samoma body, that's basically synonymous with papillary thyroid cancer. So this may come up in tests, which is why I highlight it. I have no idea what causes it, by the way. I just know that it's associated with papillary thyroid cancer. And finally, for the other ends, the folliculars and the Hürthle cells. The follicular cancers, this is on the left side, there's what looks like just a group of kind of ugly looking follicles, but it's breaking through a membrane right there. That's why we have to do diagnostic lobectomy on these patients, because it's where we see it breaking through that membrane that really gives us the diagnosis that it's a cancer and not just a benign follicular neoplasm. Same thing with the Hürthle cells. And if you're like me, you wonder, what the heck's a Hürthle cell? It's called an oxophilic cell carcinoma, which also doesn't really help because oxophilic just means it looks red under the microscope. So it's a red cell carcinoma. Okay, cool. We thought it was like a variation of follicular cells, but it turns out smart people have done genetic studies, and it looks like it's a distinct entity compared to the folliculars and the papillaries. Like the follicular cancers, you need to see it breaking through a capsule to tell whether or not it's a cancer, which is why Hürthle cells we do diagnostic lobectomy on. And unlike follicular, it has less propensity to concentrate iodine, which makes us a little bit more concerned that it's going to be more treatment refractory, so we have to be more aggressive with the treatment. That hasn't really borne out in any study. This is going to be a recurring theme of today's talk. It hasn't really borne out in any of the studies that we've done, but doesn't mean that we're not going to treat it aggressively anyway, because that's what we do. It's, yeah, so going back up. Another thing about micro, just in general about thyroid cancers, which is why we're going to go into why we overtreat them. These are frequently multifocal. When we do autopsy studies, about 20 to 30% of patients that die from other reasons have a thyroid cancer. And when we take out total thyroidectomies for a focal thyroid cancer, they may see a little bit of thyroid cancer on the other side. Up to 80% of these patients that are clinically node negative will have occult nodal mets, and doing more extensive node dissections on them. If you've been on D team, you know how I feel about extensive node dissections and whether it extends survival. Same thing applies to thyroid cancer. And despite all those factors, generally favorable prognosis, even if people have metastatic disease. And we'll go into that in a second. So first off, is there an epidemic of thyroid cancer? It seems like there would be. On the top, this is United States data for our trends in thyroid cancer incidence from the 70s to early 2010s. Overall, thyroid cancer more than doubled. This is a logarithmic scale. More than doubled over that time frame, driven almost exclusively by increases in papillary thyroid cancer. Follicular cancers, there's a small uptick in the early 2000s for reasons I don't quite understand. Anaplastic thyroid cancer, which is ugly, don't like it, stayed the same. It's very rare, thank God. And then the others have been kind of going around. This is driven almost entirely by the fact that we have really good imaging and access to imaging. So ultrasounds, same thing here. This is no need to worry about that. So is more and more. So over the same time frame, this is memorial data, but they do a lot of thyroidectomies there. You can tell that starting in the 50s when we got radioiodine, we thought, this is great. We can treat thyroid cancer with radioiodine. It's gonna be great. You can see a dramatic increase in the amount of patients getting radioiodine from the 60s to present. Same as total thyroidectomies. But at the top is the 10-year thyroid cancer specific survival, which is hovering around 90 or more % the entire time. So are patients getting better because we're doing more aggressive treatment? Think about that as we go along. Foreign answers, workup and treatment. All right, Chief, get to the point, girl. Okay, fine. All right, going to start in the front row. Viera. So if on your history and physical, patient says, my voice has been changing and I'm getting hoarse. What does that say to you? Of what? Good. Abby, it hurts. My neck hurts when I turn my head. What that might suggest. Yeah, oh, nerve muscle involvement. Cool. We're not talking about compression, but it could be invading, which is the other thing. Invasion can cause some of these same things. Rapid growth next to Abby. Sorry, I don't remember your name. So it's like, I got a lump in my neck, and now it's like really big. Yeah, cancer. But particularly for thyroid cancers, we worry about anaplastics. So the differentiated thyroid cancers kind of percolate along for a long time until something kind of tips them. And there are papillary thyroid cancers that just look terribly ugly, but in general, the more rapid ones, think about anaplastic thyroid cancer. So that patient needs an expedited workup because we actually have some treatments now for it, unlike what we used to. And then dysphagia. Very good. Esophageal, or again, nerve involvement, but typically esophageal involvement. All these are these red flag symptoms that we talk about with a neck mass, which you should be asking because that definitely influences our workup and subsequent treatments. Okay, real quick. Sorry, back row. Kevin, someone says I have a nodule in my thyroid. What are you going to do? Ask them whether it's hot or cool. Yeah, how do you figure that out? I say, I don't know, doc. Why don't you tell me? Ask them if they need a test to figure out it. Yeah, what's that? And they say, I don't know, doc. What test should I get? Close. I think I just start out with like thyroid function tests. So everybody with a new thyroid nodule gets thyroid function tests and ultrasound. They just do. Okay, cool. Now, Kevin, it's a hot nodule. Okay. It's hyperthyroid, they're hot nodule. What are you going to do? Is that cancer? Exceedingly rare for hot nodules to have cancer. We're talking like case reportable. So just treat it. You can treat it with radioiodine. You can treat it with thyroid medication, or you can do surgery to remove the hot nodule like we did last week on that dude. I don't know if his path is back yet. Okay, cool. Okay. But say now, for example, they're euthyroid carcin, or they're even hypothyroid. So if the nodule is less than 1 centimeter, or it's like a cyst, what do we do? High five. Yeah, you're done. Go talk to an endocrinologist. All right. Now it's solid. It's greater than 1.5, but it doesn't look suspicious. We'll go into what suspicious looks like. I know Vreeland already covered that too, but we have some pictures for it. What then? Yeah, do it. If it's bigger than 1.5, general, just do the FNA. If it's solid, greater than 1, but it looks ugly, what are you going to do? Yeah. These are pretty safe answers again. And this is how it looks. So simple cyst on the left, that looks great. Clear borders, hypoechoic, uniform, leave it alone. It's a cyst. Spongiform, and they'll tell you whether this looks like a bathroom sponge in a nodule. Leave it alone if it's less than 2. But now we're starting in that taller and wide, and Vreeland gives a great example about tall versus wide. If it's taller than wide, it's resistant to compression by the thing, which says if it's a more solid component, it's acting like it. The nodule on the left is still probably wide as tall, but it's got these concerning microcalcifications, and it looks like it could be growing into other things. Biopsy if it's greater than 1. There's one on the right side, ugly looking microcalx. It's taller rather than wide. Biopsy if it's greater than 1. And then these two, these don't project very well, and I'm sorry about that, but on the left side, you see a left thyroid lobe nodule, which is highly irregular borders. It's hypoechoic, it's indistinct. The third one the one on the right looks like Mickey Mouse. These are both biopsied in our cancer. That's, these do not look like benign nodules. Did we already go over the Bethesda stuff? Bethesda is like Bio-Rads, 3 or more, you have to do something, okay? So old school. The problem with them is the 3 and the 4. The treatment challenge always lies just with Bio-Rads and Lyrads 3s and 4s. You got to do something, but you don't know exactly what. So 3 is atypia of uncertain significance, or a follicular lesion of uncertain significance. Both of these carry a cancer rate anywhere from 6 to 50%. That's not very helpful, right? And that depends on your locally on how good your cytopathologists are, which is what we talk about that. So if we know that our cytopathologists say, like, every time they call it that our explant rate is about 50% cancer, that really steers us more towards a surgery treatment. If they're like they really are here and we have no idea what they're talking about, that really steers us more towards repeat biopsy or do other things. Follicular neoplasm, same thing. We can't tell if it's follicular adenoma versus follicular carcinoma. We need to do something else to figure that out. Typically, that leads to diagnostic lobectomy. Unless it looks really concerning under the microscope, then you talk about treating it, presuming it's a cancer. Nowadays, we talk about genomics. You may have encountered this in your other rotations. One of those is Afirma. It just takes the nodule and runs a bunch of genes on it. The other one's called ThyroSeq, runs a bunch of genes on it. We don't do that much here because we found that they don't really change our practice. They're both classically thought of as a rule in or rule out test. Neither have been validated in a rigorous fashion because it also depends on what, like that first part here, is what is your overall rate of cancer in your Bethesda 3 category. That pretest probability really affects how the test performs. And we don't like it that much. And does one work better than the other? They've done one randomized trial and they work about the same. So either test has about a 90 to 100% negative predictive value in patients that have made it onto surgery. So a negative test, 90% chance it's not cancer, but that's in patients that got selected for surgery. So the jury's still out. We don't use it that much here. Just be aware that these things exist. And if you're on the fence, the patient really doesn't want surgery, this may be one of those things we can offer them to say, like, well, let's take a look at it, knowing that a negative test here gives us 90% chance it's not cancer. We can take our time figuring this out. If they don't care, then it's a waste of your money and probably just take it out. Incidental thyroid nodules, we see more of these and more of these, the more PET scans we get and the more CTs we get for trauma. Brass tacks follow the same pathway. Thyroid nodules, normal thyroid is not very FDG avid. So if you see an FDG avid thyroid nodule, there's some controversy on how aggressively to work them up and manage. But again, depending on your center's experience and expertise, these things can have up to a 30 to 50% cancer rate. So this is one of my patients actually that had Merkel cell cancer. It's a skin tissue it's a skin tumor. He had it over his clavicle. We were doing this to stage Merkel cell cancer. I'm like, great, what's on the thyroid? We took it out. It was really hot, so its SUVs were like 40 to 50. So we took it out, and it was a hobnail cell cancer. And then there was a lot of controversy about what if we need to do a completion thyroidectomy and radioiodine, which I'll get into in a little bit, which we didn't. So safe answers again for the Chiefs. For differentiated thyroid cancer greater than 1 centimeter, total thyroidectomy and central neck is always a safe answer. You don't need to do either of those, it turns out. We'll go into why. Selective node dissection, not berry picking. So if you're concerned about a lateral node in any one of the levels, you're going to do a selective node dissection of that level. You're not going to be like, yoink, got it. You're going to do the formal thing. And if you're talking a board scenario, you're going to know those boundaries. We'll go over those boundaries in a second, but you're going to clear out the nodes in that area. And after that, you get your final path back. You're going to discuss radioiodine. Again, you're going to discuss it because the radioiodine data are not there at all. There's never been a randomized trial looking at different doses of radioiodine for different stages of thyroid cancer. So let the nuke med guys and the endocrinologists talk about that. Node levels. This is not a talk. We're not talking about surgery today. We're going to talk about thyroid cancer. Just know your node levels. Okay. There's many textbooks. They all have definitions of the levels. And like I said, you're going to do a selective node dissection of the level. You don't need to do a modified radical. You can do it. You can do an isolated 3, an isolated 4 if you need to. Thyroid's out. Now what? Back row, Spencer. So we've done a total thyroidectomy. What's our generic postoperative management for the patient? Okay. Okay, good. We all put them on calcium post-op here. That also has very little data behind it, but there is like a D-team standardized practice for this. Total thyroidectomies get calcium supplementation to prevent post-op hypoparathyroidism. If they have a thyroid cancer, we typically get a post-op thyroglobulin level. And why is that? Could be. Or if they have thyroglobulin antibodies, Is that going to be a helpful test moving forward in their treatment? Good. And so this is something we do use to follow the disease long term, but we also get a thyroglobulin antibodies because there's enough patients that have those antibodies that render this test not very helpful. So we want to know that moving forward. And then, like I said, then we talk about them in tumor board and we talk about radioiodine based on their clinical risk and institutional preferences. And then depending on the tumor itself, we might put them on thyroid hormone, not just to replace the thyroid hormone they've lost, but also to suppress their TSH. And again, that's based on their clinical risk and what we see in the operating room. All of these, very little data. We just do it because it made good sense and the risk-benefit profile made sense to us too. Prognostic influencers, age. Age is one of the biggest, most important things in how these patients do over the long term. Used to be 45 years. I think the new risk stratification is 55. Doesn't really, the younger the patient, the better they do. And there's some pretty compelling data for that. Whether they have metastatic disease, most commonly that's lungs. It can be bone. It can go to a lot of places, but most commonly lungs, bone. Tumor burden, and by that I mean how big the tumor is, whether it's invading other things, and how many of the nodes are involved with it. And then there's about 16 different ways that we can classify that. So choose your own cool classic. They all perform about the same. MESAs, games, and so MESAs is METs, age, something, extrathyroidal extension, symptoms, games came from Memorial. That's the one I use because I was at Memorial. And that's grade, age, METs, ETE, and something else. And then the ATA guidelines. Choose one, use it. They're all a little bit different. They all define low risk a little bit differently. So just own your stuff. So this is the Memorial data. Again, age. This is how important age is. So these are patients younger than 45 that had metastatic disease at diagnosis. Their 20-year thyroid cancer specific survival was 90%. So that's like, but then age greater than 45, definitely there's something going on there. So better to be young if you're gonna have thyroid cancer. For example, so now our risk groups, right? So this is the paper talking about the GAIN score, again, at a Memorial. So I think 5 risk factors. One is the age of the patient. The others are the grade of the tumor. And so they said the grade is like papillary versus not papillary. And whether they had metastatic disease, how big the tumor was, and was there extrathyroidal extension. So a low risk patient was young, less than 45, and had none of those, and had no METs, papillary cancer, small tumor, no thyroid extension, all of those. A high risk patient was older than 45 and had any of the not papillary. They had metastatic disease, they had a big tumor, they had extrathyroidal extension. Everything else was intermediate. The breakdown of these kind of patients over time, about a third, give or take, of your patients are going to be low risk. Their 10-year thyroid cancer specific survival is 100%. The high risk patients, so old patient, ugly tumor, their 10-year thyroid cancer specific survival, whether or not they're going to be alive without thyroid cancer in 10 years, is still around 90%. So we'll use this to frame the discussions with your patients, which we're going to in a second. These are the ATA risk groups. American Thyroid Association, sorry, this is one we use very commonly here. Same thing, intrathyroidal tumor. So now we talked about biology of tumors earlier, right? So biology really drives everything. They can have up to 5 nodes with metastatic disease in the nodes. It's still low risk. If it's an intrathyroidal tumor and it has a favorable histology, less than 5% of those patients recur. Intermediate risk, aggressive histology with a big asterisk by there because that's that tall cell, that hobnail that we talked about, or maybe like the ugly folliculars, stuff like that. Minor extrathyroidal extension, which means like they see it microscopically positive, but you didn't notice that in the operating room. Or if it had vascular invasion, more than 5 nodes involved, anywhere from 5 to 40. So that this seems like a good group to target with clinical trials. Unfortunately, we haven't done that. And then the high risk is like, it's ugly, it's invading things. You didn't get it all the way out because you were worried about nerves or having to do a layer injecting when you get it out, that kind of thing. Large nodal burden, or they already have metastatic disease. This is recurrence. Now, important, recurrence does not translate into long-term survival, right? So this thing was about, these things talk about disease-specific survival. They do not talk about recurrence. How do we treat recurrent thyroid cancer? Does anybody know? Send us. Is it treatable, I guess I should say. Well, there's a Goomba come back in their neck and maybe in their lung. Yeah, you can ablate it, you can operate on it, you can radiate it. The key with the recurrences in thyroid cancer is many of them are salvageable or operable. as opposed to say, I don't know, pancreas cancer. Kat Thomas, what do we do for recurrent pancreas cancer? Medical oncology, margarita on the beach, right? And so that's the difference. So recurrence is important, but in terms of something like thyroid cancer, where you can salvage or you can treat the recurrences, just because they recur doesn't mean they're going to die from their thyroid cancer. Very important. Okay, let's do some guesstimation. Bobby, so this is a 4-centimeter tumor with a 1.5-centimeter intrathyroidal nodule, which also looks concerning. Which risk group? And this is a young patient. They're feeling fine otherwise. Which risk group would you put them in? Yes, very good. Okay, bigger tumor. It looks like it's extending outside the thyroid, maybe encroaching upon the carotid sheath, and they've got some obvious central node mets. Lexi? Yeah, also intermediate. That's the thing, right? Okay, this one. It's all over the place. In the back. Iris, there you go. That's simple. So a word about recurrent cancer, like we talked about, surgery is still the treatment mainstay. Like everything else, recurrence and metastatic disease is an exercise in patient selection. Who is going to benefit the most from your treatment? From the retrospective data, there are no prospective data about this. It is younger patients, right? So young patients with metastatic disease still do really well. They have a subclinical presentation, meaning you just diagnosed it on follow-up. You didn't diagnose it because they had like a giant neck mass compressing their trachea. And if it took them a long time to develop their recurrence. So these are all things that are kind of like generic to any cancer, not just thyroid cancer. Long disease-free interval, subclinical presentation, younger age, because you can throw more treatments at them, right? And then if it recurred in the neck, it's easier to treat something that recurred in the neck than recurred like, in the thoracic outlet. And if you can get it out. 3 things to treat. I don't know if this will come up on boards, but you have three things you can treat easily with any recurrent, which is surgery, more iodine, and external beam radiation. Okay. So there's the board answers. Those are the safe ones, right? Now let's go into the controversies. Lobectomy versus total for thyroid limited tumors. So there are no prospective studies on this already. Abundance of cohort data, that's all we're using for this, suggests that a lobectomy is okay, which is why the guidelines changed in the last 3 to 5 years. There was a big study using, I think, the National Cancer Database that said like, oh, well, a total thyroidectomy seemed to have a decreased overall, or had an association with improved overall survival compared to lobectomy, but it turns out we did a really bad job of coding thyroid cancer operations. So many people were getting a lobectomy were getting coded as a total, so the data were all crappy. So they did some more rigorous studies using either the same data or large national databases subsequent to that. And they found out that lobectomy had basically equivalent outcomes, which kind of makes sense, right? These don't seem to be very aggressive tumors in general. So less surgery shouldn't really get in the way. What we keep seeing though is radioiodine use goes up as surgery goes down. There he goes. So again, safe answers for the chiefs and for people taking their boards. Got to have these 4 things. Classic papillary thyroid cancer. That's the only histology they allow for this. Classic papillary. Intrathyroidal, meaning it looks like it's completely surrounded by normal thyroid tissue. No nodes, no mets with good imaging. So you're not just saying like, I looked at them in my clinic and they looked fine. So they got to have like the real ultrasound, maybe a CT, and no prior radiation. If they meet all 4 of these and they're going to follow up, lobectomy is okay. They got to be able to follow up. And they got to be able to do all those things. Otherwise, total. Okay. Basically, and then all others total, which is why total is still very much a safe answer on your boards for this. For follicular neoplasm, it's different. Diagnostic lobectomy, everybody kind of gets one of those. If it's an invasive, and we do the total. If it's minimally invasive, God knows what that means. Or if it's one of those weird NIFT-Ps, which is the encapsulated follicular variant of papillary thyroid cancer, you're okay with the lobectomy. This is a distillation of the NCCN guidelines. It still stands. I checked it last night. Extensive nodal dissection, there's one underpowered prospective study. So like we talked about earlier, these cancers go to nodes really quickly. So when if people don't have clinically apparent nodes, up to 80% of them will still have pathologically involved nodes in the central compartment. They go to the central compartment that is between the carotid sheaths, north and south. Up to 5 to 20% of patients that get total thyroidectomy with dedicated node dissection. Up to 80% of them, depending on how old your data are. The lateral neck nodes, less common, but it can still happen. Clinically apparent, and we already talked about that. So the big question was, do we just do central node dissections on everybody that's getting a total thyroidectomy for cancer? And that became hotly debated, still is, I guess. There were centers that did a good job of it, and they said our outcomes, our recurrent nerve injury rate and our hypoparathyroidism rate is low enough. We think it's worth the risk, and it shucks out all of the node disease. And that way we can maybe spare them radioiodine. And there were other places that said it doesn't matter how many of those central nodes are involved if they're not clinically apparently involved. And taking them out is going to subject the patient to unnecessary risk anyway. So there is a lot of this in it. So consistently what we've shown is even though there are 15 to 40% occult nodal mets in the modern era, there is less than 5% nodal recurrence. This is a common theme in cancer, right? Even though there may be some clinically apparent nodes, doesn't mean those nodes are going to cause a problem. Here on D team, there's 2 disease processes that show this out really well. What's one of them? Sarah. Yeah, melanoma. And the other one? Breast cancer. Very good. So just like breast cancer, we know from a long time ago, we leave disease behind in the nodes and up to 40% of our patients. Those don't always cause a problem. Thyroid cancer is a very similar thing. We can leave disease behind in the neck because we have other treatments for it. So you don't necessarily need to go shucking it all out. That was the argument for the let's not always do prophylactic central neck dissections. Very consistently double the complication rates. Nerve injury rates double, hypoparathyroidism rates double. Now, your baseline rate really drives that. So the memorial data, and I don't believe this, are like, we never caused that problem. No, that's just a memorialism. Like, we did it in all these people and we never had a problem. Like, no, you did. They're lying. There was a larger Korean study. The Koreans do a lot of these operations as well because they love doing neck ultrasounds, and they do a lot of thyroid surgery because they do a lot of neck ultrasounds. Their data very consistently showed double the complication rate when we're doing central neck dissections. No apparent survival differences, no matter the study that you look at. There was one randomized controlled trial out of Italy, I think, 6 years ago now. Oh, getting old. 181 patients. It was not powered for survival. It was powered for looking at surgical outcomes. To do a survival powered study for this, you'd have to do about 6,000 patients. So yeah, it's not undoable. It's just that people see that as a major hurdle. But we can do this in breast cancer. Thyroid cancer is common enough. We could probably do it in thyroid cancer too. Interesting that we haven't, right? So this was the trial. They took people with clinically node negative thyroid cancer, and they randomized them to thyroidectomy and thyroidectomy plus a central neck. What they showed, about 3% of the time that the central neck actually changed management, either for or against radioiodine, as opposed to 1% with a thyroidectomy group. One patient ended up getting radioiodine that they didn't plan on doing it based on some other findings that they found with some parathyroid nodes. So 1 in 50 chance you're going to actually change your management. The 2 things that bore out really nicely is multiple iodine courses. This is driven by postoperative thyroglobulin levels. So in the patients that didn't get completion node dissection, they had 4 times the rate of requiring multiple iodine treatments to get their thyroglobulin levels down, as opposed to the central neck dissection group. They usually just required 1 treatment. No changes, no differences in persistent disease, double the cord palsy rate, about double-ish the permanent hypoparathyroidism rate after surgery. So this is the only level 1 data we have for central neck dissection right now. Observation for microcancer. So we talked about now microcancers. Yes, Dr. Vealing.
I have a question about that trial. I'm sorry, I'm not aware of the answer. You know, in the thyroidectomy group, did they like selectively take out nodes that seem kind of big? That's right. What most of us do in practice now is like,
yeah,
they're like, anything that looks even remotely suspicious, I'm going to take out, but I'm not going to like thoroughly clean out the central neck because then I know I'm going to take out.
Yeah, they did, and the reason for that management change, because like they found a couple like parathyroidal nodes that weren't like an intentional central neck that had some cancer that they then said would do it. And like we were talking about, like in Sarah, like in the case of the day, if I know I'm going after a thyroid cancer, I'm a little bit more generous about the soft tissue that I'm cleaning out in the neck than I am for like just goiter or something like that. And so they were doing some of that. But they did. I mean, they really harped on that, like they didn't do a formal anatomic template-driven resection, for what it's worth. But I think what's interesting is what I would tell the patient is, at least in Italy, you know, only 1 in 50 patients will have their planned management change as a result of the dissection.
The other thing that I wonder, you know, is the relevance of this trial is when the APA guidelines changed. You know, how it started anyway.
A little. We do,
yeah,
but not everybody.
we're going to be fine. And if we were going to apply it here.
Yeah.
I mean, we basically, you know, if you do less, fewer total thyroidectomies, you're going to have your patients that you can follow.
Come again? This is central neck.
Well, I mean, I guess if you're doing, yeah, I mean, I guess if you're not, the reason we do a total is so you can get radioactive iodine.
Now, we're not talking about total. We're talking about central neck dissection.
I know, I guess what I'm saying is the reason that they get more radioactive iodine is because it's a monitoring thing that you're following them, and that's always been the argument that, you know, to do the central neck, to do this is so that you don't have to go back as often. So you can't surveil the patients to find out if they recur, you know, that's the argument. But I guess if we pull back on surgery in general, like on the thyroid surgery itself, then this is less of an issue. Does that make sense?
I guess. I think it speaks to the point that we're just kind of spitting in the wind when it comes to thyroid surgery and cancer management anyway.
Well, it's because
But I take the point, but
it's because it's not an unmet need. You know what I mean? It's not like we have everybody out there dying of thyroid cancer. It's hard to argue that we're making a big difference. I mean, you know, there's other data that we'll talk about tomorrow in the screening trial, which is like basically you look for thyroid cancer more, you don't look for cancer.
yeah. Oh, you weren't here for that part. Yeah. No, so yeah, so this is great because you're speaking exactly to the point. We don't exactly know, like there's no trial that shows that we actually need radioiodine, right? There's never been a trial that showed that radioactive iodine compared to surveillance improves survival, thyroid cancer specific survival. Just hasn't been done. And so now we're giving like these not random, but there's a lot of heterogeneity in dose of radioiodine. There's a lot of heterogeneity in timing of it. And now we're starting to peel back on the surgery side of it. People were worried, I still worry that means they're going to be increasing the amount of radioiodine because like, well, the surgeons are doing less surgery, so I'm going to give more radioiodine. So, and it's ripe for a trial. It's unfortunate no one's done it. It's a common enough cancer that it could be done.
But also to your point, it's like the trial is hard to do because you would have to follow so many patients for so long.
Yeah.
Do you feel like the prophylactic that's all they do is that they tend to get the recurrences and they see this one stick with them and we have to go back in the snack.
Yeah.
And like, you know, in reality, not very common business. That's the only thing you do when you're a referral from the court. And then you see data like this that says persistent hyperparathyroid is higher. If you have, that's all you do. That doesn't apply to you because you're better than
Yeah.
And that's justified.
Yeah. So you go back to the first slide where I said you got to know your data. My hypoparathyroid rate is probably about 10% after these operations, and so it makes me consider it every time we're doing it, right? Okay, so microcancer, the new hotness in microcancer, so less than 1 centimeter papillary thyroid cancer is observation. This is driven by the fact that autopsy studies, people die with papillary microcancer, they don't die from it. So people started asking, do we even need to operate on it? And brass tacks, this is all observational data. It was driven in large part in this country by the Memorial Group. It's spreading out now, but this is the study that they like to kind of harp on right here is how do these things change over time when you're serially observing them? The majority of them don't change, right? So that's that kind of dark gray bar on the scatter plot. Those are tumors that essentially didn't change. And this is volume, it's not diameter of the lesion. And about 10% of them grow. They increase in their volume 50% over serial observation to the point where they would do a lobectomy on these patients, not a total thyroidectomy. But the majority of these patients will either stay the same and a small percentage of them actually shrink if you follow them over time. This mandates a particular thing, Lexi. If you're going to observe microcancer, what must you have as a center and as a patient? Yeah, exactly. So if you're going to offer this, you need several things. They talk about inappropriate patients, and that is people that are really young because you're going to be observing them forever. unlikely to comply. So a lot of our patients, not because they're bad people, but because they deploy, and you don't know if they're going to deploy or move to some place where they're going to be able to get reliable follow-up. Inexperienced team, which is, sorry, the MTFs, and ugly tumors and nodes. So if it's like right up on the trachea and like kind of close to the nerve or anything, that's not something that you want to kind of sit on. So the group would say like, this is not something you would do. Okay people, middle-aged patients willing to comply, experienced team, duh. And then ideal patients will be your older ones, willing to comply with you in a weak sauce tumor. And so the bottom is all kind of the tumors that we're looking at. If it looks like you could easily get it out regardless, and it's in an old patient, they're more likely to die from something besides their thyroid cancer anyway. And if they're willing to go to follow-up. So you need to meet all these things to say that it's okay. So again, for the board, you would say like, I would consider observation, but only if these things happen. Otherwise, they're getting surgery. Okay, final thoughts, because we are 10 over. Some pearls for boards and testing. If you see thyroid tissue in a neck node, that's thyroid cancer. So that came up on one of my oral boards. I guess I'm not supposed to talk about that. But anyway, so if you see that thyroid tissue never exists in a lateral neck node, it's thyroid cancer. Thyroid sarcoma, you'll hear it on pathology calls. That's typically anaplastic thyroid cancer. It's just that's how ugly it looks under the microscope. They say it looks like a sarcoma. Atypical subclavian jugular junction, when we're doing our neck ultrasounds pre-op, think about a non-recurrent nerve for your operating room planning. This will come up in a couple, I guess next week, I guess we're talking about hereditary colon cancer, but people with FAP, people with an APC mutation, they get papillary thyroid cancer. And anaplastic thyroid cancer used to be, still is, like very feared because it grows aggressively, it can cause airway compression. Before, when I was starting training, the only thing we really had for them was external beam radiation and tracheostomy. But now we have targeted agents for BRAF, and BRAF is frequently mutated in those cancers. So we have genetic testing, we can have more targeted therapies for it. And so if you catch it early, they can have long-term survival as well. So it's not, it was billed as a death sentence in many books and stuff like that. It's no longer that way, but you still have to jump on it, and you have to get genetic testing on it to see if you can have some targeted agents for it, because it's pretty treatment resistant. I think that's it for today. Like I said, we're not talking about surgery or anything like that, but we're going to talk about the basics of it. Final questions, thoughts? Yes, sir, Dr. Clifton.
So for the micropapillary cancer, how do you find it to begin with? The rest of the guidelines say not to last anything under 2 years.
Yes, that's typically how they found it.
Man,
Inappropriate biopsy, honestly. Yeah, yeah. Yeah, my one observation patient, that's it. It was an inappropriate biopsy.
That or at the time of surgery for some other, doing it low for another nodule, microcarcinoma also. Sure, but this stuff's gone. But you try to decide whether it's there or not. Sure. Oh, yeah.
Yeah.
I guess the one time I wonder, the one time I struggle with is what you do if you have a 2 centimeter papillary thyroid cancer on one side and then a 9 millimeter thyroid or the other side, but that one,
Mm-hmm.
you know.
So it's still, I think, yeah. My patients are typically already asking for a total by that point, because they've been referred by referred by endocrine who said like you should get a total thyroidectomy. So it's kind of already in their head. So most of the time I usually say, okay, because it's 1 to 4, but it's multifocal disease. So you can get, it's a fine sell to do a total in that case. The one challenging patient we've had is that guy that had that incidental, basically hobnail cancer, that I was doing it just to shuck out something hot from his neck so we could surveil him for Merkel cell. And it came back with like, it had hobnail features. And then I was on the phone for like 3 days with medical endocrinology. You got to do a completion because we're gonna give him radioiodine and this, that. And it was a 1 centimeter thing. And it just looked really not that concerning. And so when I called, I called the mothership and I said, what would you do with this? And every single one of them was like, the hobnails is really low on that list of risk factors for like disease. Like if it's a small tumor, it was in the thyroid, and there was no clinically apparent node disease, he's still going to do really wonderful. His thyroid cancer specific mortality, he's still going to die from the Merkel well before he's going to die from the thyroid cancer. So we just observe him. And that's the one. A lot of it's talking our medical endocrinology colleagues kind of off that. It's like we need to do a total, and like we need to give him radioiodine. We usually respond with like, I'm not sure we need to give him radioiodine, but we can talk about the total.
I would say managing anaplastic thyroid
Yeah. I think so. And like historically, when we had nothing else besides radiation and tracheostomy, like they were appropriately concerned. But like the newer data are showing that it responds really well to vandetanib, so BRAF and MEK inhibitors. It responds pretty well to those drugs, and we're changing the disease course now. So there's a lot of that education saying we're changing the disease course for this particular cancer.
The difference